Good afternoon, everyone, and welcome to the April 6th, 2023, Season 3 episode of Ask Us. The show is hosted by Clinical Trials BC, part of Michael Smith Health Research BC. We work to strengthen the clinical trials ecosystem, to maximize the health, educational, economic benefits of clinical trials in British Columbia. I am Jean Smart and the host of Ask Us and the Regulatory Affairs and Quality Officer at Clinical Trials BC. We acknowledge with respect and humility that our Vancouver offices are located on the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Today, I am at the point of land on which UBC sits. And here outside of my window at the edge of the Salish Sea are beautiful stands of old growth fir, many creatures and many peoples. And this is the place of the Musqueam Nation. Our producer today is Nhan Do. Nhan?
Hello, everyone.
Okay, good. And I'm pretty excited about today's episode. The format is, we always try to shake it up a little. The format today is a guest presentation, an expert interview, followed with your favorite, some question and answers, period. I'd like to thank very much all of those of you who sent in questions in advance. We've tried to incorporate them. But you can still put your questions in the QA or the chat box, and we'll certainly try to get to some of those. Our topic today is on cluster randomized trials, the ethical design, data integrity, and consent for cluster randomized trials. So the Ask Us question is, what should research teams know about consent requirements, expectations around collecting data for cluster randomized trials? Informed consent, it's a cornerstone of all ethical human research. Cluster randomized trials, CRTs, a new acronym for you, are increasingly popular to evaluate health service interventions, especially as health systems are moving strongly towards learning health systems. The new ICH-E8 document on general considerations in clinical trials highlights and emphasizes, very strongly emphasizes, new approaches, new designs, and new sources of data. And the E6 document, GCP, is moving towards principles and reasonable and adaptive trials. So there's a swirling questions around how research teams and research ethics boards should navigate intertwining consent and data utilization considerations. This episode of Ask Us will present the basics and examine how researchers and REB team members can consider the ethical dimensions of when data can be collected and utilized in CRTs in the evolving research and regulatory landscape. So we have today, I brought in the experts to help navigate this new and exciting topic. Co-hosting with me today is Alison Orth, the Director of Clinical Trials BC, and Terri Fleming, the former Director of Research Ethics BC, now the Director of Operations at Michael Smith Health Research BC. Terri has over 20 years experience in ethics and compliance consenting, and Alison has the same in clinical trials conduct and leadership and management of clinical trials at sites in the institution level. So welcome back to Ask Us, Alison, and a very warm welcome to you, Terri.
Thank you, Jean.
Thank you.
So let me introduce our guest for today. We are really pleased, Terri and I are very excited to be having a conversation with Dr. Anita Ho. Dr. Ho is a bioethicist with a unique combined academic training and experience in clinical and organizational ethics, public health, business, and philosophy. In addition to being a scientist at CHÉOS, Anita is currently a clinical associate professor in bioethics and health services research at the Center for Applied Ethics at the University of British Columbia and an associate adjunct professor in the bioethics program at the University of California, San Francisco. And you're coming to us from California today, is that right, Anita? So welcome to Ask Us, and we're very pleased to have you here.
Thank you. Thank you so much. I really appreciate this invitation and this time with you. I know that I'm standing between you and the long weekend, so I really appreciate everybody for joining in. Is this a good time for me to start sharing my screen?
Absolutely. Okay. I think that we're looking forward to a bit of a primer on cluster randomized trials and the project work you've been, the research you've been leading. Thank you.
Sure. Yeah, I would say that primer is a very good way to sort of describe this. So depending on how experienced people are in already using cluster randomized trials, so this may be something that you have already thought a lot about. Some of you may be starting to think about using this as one possible design method for your research. So I'm mostly focusing on the research ethics aspect, and I would really encourage everybody to talk to your statistician, epidemiologist, when you think more about what would be the most appropriate trial design, given the population that you're serving and the particular research questions that you may have. I'm really excited about this project and discussion today, partly because I've had a lot of experience serving on research ethics boards, but that I think that sometimes even I myself struggle with some of the questions given, what principles may be out there, and then what the realities may also be facing all the research teams. So before we start, I would like to also add my land acknowledgement. I really like this in particular painting done by Christy Belcourt. Part of the reason is because I think it really speaks very well in terms of how we're all together, learning together, doing our research work together, even if we may be differently situated. As a UBC faculty member, I also have, I'm grateful for the opportunity to be working on the unceded territories of the Coast Salish people, for the Musqueam, Squamish, and Tsleil-Waututh Nations peoples. As being mentioned earlier, I'm currently in San Francisco. I'm here for the American Philosophical Association conference, and San Francisco is the unceded territory of the Ramaytush and Ohlone peoples, and so I feel privileged to be able to work and learn in different lands. And this painting talks about how the plants are our teachers, and they're connected to each other. And just like I think that very often research participants and researchers are also connected to each other. And we are learning from each other through the sacredness of life. And Belcourt talks about how when she remembers who she is, a human being connected to all of life, and she remembers also that she's loved by the spirit world and our ancestors. And she says, when I remember this, I remember to respect even the smallest of things. I really appreciate her curation of this art as well, partly because I think that when we talk about research, when we talk about consent, we're often thinking about respecting those who are part of research. But sometimes when we're doing pragmatic trials, what respect really means, it's not always so straightforward. So often we are using informed consent as the cornerstone or the main tool that we have to show our respect for human participants, to allow them what I would call the binary choice of either be part of or not part of research. But cluster randomized trials, which are now increasingly being used for health services research or implementation research, often evaluate various complex multi-step and multi-component interventions. And as the name might suggest, in many different situations and different places that may have different realities as well. The Tri-Council policy statement that I'm sure that all of you are familiar with does promote respect for persons, concern for welfare and justice as the guiding ethical principles. At the same time, it also recommends using a proportionate approach to research ethics review. So Jean also mentioned earlier in terms of how do we be more reasonable when we look at very complex trial designs. In more recent years, the Ottawa Statement on the Ethical Conduct of Cluster Randomized Trials give further recommendations in terms of how we can think about consent. It does take a more pragmatic approach, but also recognizes that we meaning researchers, have the fundamental obligations to research participants. So they recommend that we should still provide consent opportunities for all research participants, but that if being reviewed by the REB, that it can also, the REBs can allow consent waivers if two conditions are fulfilled. One, it will not otherwise be feasible for the trial to continue without a consent waiver. And two, that this trial does not have more than minimal risks. So what I and my research team has been looking at is what exactly are the experiences of research ethics board members in reviewing cluster randomized trials and considering ethical obligations? And what are cluster trial researchers' perspectives on the process in getting consent or considering consent requirements? So this project was funded by the BC support units. I was one of the interviewers with Dr. Sudhi Julie, who is now, I think, the research manager at Fraser Health. We had other team members as well as an advisory team that has experts and also patient representatives. So why think about new ethical approaches in talking about cluster trials? So on the left, you see this diagram for the more regular, simple randomized controlled trials. So these are trials that are often used for drug development. I'm going to use psychiatric situations as an example for both of these situations. So on the left, you can imagine situations where companies or a health system may be trying to see whether the new psychiatric medication may be effective in controlling patients' behavior, moods, and so on and so forth in an emergency room setting. So you might be using, for example, one group that is the intervention group that is trying the new drug, and then the control group that is not using this new drug and maybe using the standard treatment. Patients would be providing consent at the bigger circle level, so before you randomize them into the control or the intervention group. People would know that they are going to be put into one or the other group, but they don't know which one yet. And then you follow up with these patients and see how they do, and then you compare the results. In the cluster trial, the ones on the right, we don't randomize at the individual level. You randomize at the cluster level. So using psychiatric treatment, again, as a possible, or intervention as a possible example here. You may have let's say, an educational module or intervention for healthcare providers. So you may have, for example, let's use hospital as the clusters. Let's say 10 hospital clusters. You will have all the healthcare providers in the emergency room to be going through this particular education intervention. The other 10 emergency rooms don't have this intervention. And then you compare the clusters to see after the education modules, whether patients in the emergency room in those 10 intervention hospitals fare better compared to those in the control group. So even though you may be testing the outcome measures, the outcomes for the patients in those emergency rooms, the intervention is actually being used at the hospital level for the healthcare providers. So sometimes you may want to look at clusters rather than just individuals, because you also want to see whether there are other things in the clusters that may be making a difference in terms of how these interventions may be implemented. So the questions that we had in our research looking at cluster trial ethics, and more generally speaking, is really to see how do researchers actually navigate these questions about consent. Should, these emergency rooms, for example, tell patients that they have this intervention, which is the education study, going on, and who should be actually giving consent? So our research was in two phases. The first phase was a systematic review of the literature out there on cluster trials and how cluster trials may be doing consent, if they're doing consent at all. We also conducted 14 in-depth interviews as part of a qualitative interview study. For all of those 14 interviews, 6 participants are researchers, cluster trial researchers. 4 interviewees were REB members, and then 4 members are researchers who also sit on REBs. We also had a patient advisory group that helped us in interpreting data, and which I thought really enriched the discussions. We have an upcoming article, I think that has been disseminated for the folks here as well, that summarizes some of our main research findings. And I'll go through that very briefly today. So we found 4 notable themes talking to researchers and RIB members. That even though most people talked about consent as one of the most important issues that they deal with, they do ask questions in relation to how do they really situate research in the learning health system environment. They also talked about how we should think about consent in the context of balancing risks to participants as well as burdens on researchers. They believe that we need to balance the right data integrity and public good in the research arena, and perhaps also go beyond individual level consent to offer other kinds of safeguards. So briefly, the first theme in terms of research in the learning health system, interestingly, we actually did not name learning health system as part of what we were thinking about, and just allowed participants to really talk about what have they been looking through or thinking through when they are designing cluster trials or evaluating cluster trials at the REBs. So the REB said that they rarely actually review cluster trials. Most of these cluster trials are actually more like quality improvement projects. So they're exempt from having to be reviewed. And for those that are being brought to the REBs, most of these trials are looking at implementation or techniques that have already been proven to be effective and safe in the more traditional randomized control trials, but now you're trying to see how they're being implemented in the real world setting. So many of them talk about how these trials may be research technically, but that REBs generally have not been really well equipped to deal with them. So many of them talked about how we need to educate REB members and the public in terms of how research is really part of clinical care delivery to help achieve a learning health system. Some of them also wondered whether we should be able to collect demographic and outcome data for patients who might refuse consent, or if all consents have been already waived. Participants also talked about how to balance the risk to research participants as well as burdens on researchers. The Ottawa statement talks about how unless it is not feasible, researchers should be getting consent. But our participants think that we actually really should think about how or whether, in the control group versus the intervention group, whether any of the practices is really deviating from the highest standard of practice. They highlighted how consent procedures often can be very burdensome for researchers and also for the participants, so that they think that if it is minimal risk and the data being collected or examined would be de-identified, that we should try to minimize the burden on researchers to ask for consent. This is especially if patients are not, or participants are not asked to do anything that is different from any standard of care. They were worried that if consent is required, that they may miss the potential of making sure that everyone in the population is benefiting from research. So that really ties to their perspective on how to think about balancing participants or prospective participants' rights, the data integrity, and the public good of promoting research. Almost all of them talked about how we need high quality and inclusive research as part of our promotion for a learning health system. They are concerned that consent requirements may sometimes lead to selection bias that can lead to also misleading or invalid results when we're comparing clusters. So even though in research ethics, we often talk about how respect for participants requires that we get consent from people, many of our participants talked about how actually, if you have that requirement and then you have a skewed sample, then in some ways you may actually be violating the rights or compromising the rights of people who are participating, who are explicitly consenting, because it may be that they are wasting their time in participating in a study that may not actually have the highest quality results. So participants think that consent and privacy are very important considerations, but they should not outweigh every other consideration. They also talked about how inclusive research is part of a collaborative necessity for us to have a good learning health system. So they think that in general, we need to have consent for most studies, but that there may be other ways to think about safeguards. If we do have independent review of risk, whether it's by the funding agency, by the REBs already, we also can then see whether there can be other forms of gatekeeper consents. So it's almost like mother hen, if you will. So clusters, when they agree to participate in a research trial, they most likely will have already reviewed the protocol, the methods, and other kinds of risks. So can they be the ones who may be accountable to the research? Participants also talked about how if we have community engagement, population level communication, and more public education about the benefits and methods being used for research, that may also enhance their understanding of research in general and why we may be doing research and how research data is used for good purposes. Participants also talked about how we may want to have patient advisory groups, and in our own research, and we did involve them as well, that they can help to at least raise red flags for any kind of research projects that you may be doing. There are situations that informing patients about participation may not be practical, but there may also be other ways to have posters, flyers, QR codes as research sites and so on that allow people to get more information. So in general, the interviewees really valued having consent, but want a more balanced approach. They want to balance how to minimize harm to participants, but also to minimize the burdens on researchers. They seem to think that impracticality is too high of a bar of raising consent, or waiving consent, because there may be questions in terms of whether there's a double-edged sword, that if we allow people to not participate, often it may be those who have been, generally speaking, already excluded from research benefits, that they will continue to not be able to benefit if they are not participating. So there may be questions in terms of whether we need to integrate a more public health lens into building ethical research. That there are practical implications in terms of enhancing research education about the life cycles and values of cluster trials, or perhaps even other kinds of trials. So what participants basically told us is that please try to avoid over or under reviewing. Okay? So REB sometimes may be reviewing too much, even when the risks to participants are very minimal. So can we have other kinds of ways to really think about how researchers can demonstrate the clear understanding of why they are conducting a certain kinds of research and how this may affect those stakeholders, and then use that as a way to really explore what may be the most appropriate and ethical ways to conduct the research. There are also ways that researchers can also document their efforts and procedures and to involve, consult, and engage relevant communities throughout the research cycle. So they can clarify how or why certain clusters are being chosen and compared. How the research questions and methods appropriately address community priorities in culturally informed manners, and how the research team may share data and resulting benefits with the relevant communities. So this is a very quick way to talk about how basically many of our participants talk about, particularly in cluster trials, that very often they're used for health services evaluation, that the most important ways to think about these issues are not simply about consent, but also much broader ways to consider whether we are really incorporating the concerns, the priorities of the stakeholders, so that we can plan accordingly and involve those who are perhaps most concerned about these issues to build ethical research practice. Thank you.
Thank you, Anita. Gosh, after listening to the presentation, Terri, I don't know about you, but I know we had a couple of questions that we received ahead of this session today, Anita, that were sent in by the attendees. We had some questions, Terri and I, that we had wanted to ask you. And now just listening to you talk and then the full presentation, I think I have another 4 or 5 and trying to prioritize which one really to start with. But Terri and I would like to ask a few questions, facilitate discussion. Some of these questions were sent in, like I said, ahead of time. And for our guests today joining, our participants, please do use the chat, the Q&A. We'll keep an eye on it. After the presentation, hopefully you also had sparked some thinking for you, and we look forward to the discussion. One of the things, Anita, we talked about was, I guess coming from the conduct side and working with those that administer informed consent traditionally for randomized clinical trials, controlled RCTs. You think about the complexities there. And the first time we encountered a cluster randomized trial, we were sort of had to take a step back and like, oh my gosh, like, how do we think about this? It's quite different for us. And as I went through that process, I realized there's a lot more complexity in how you think about that design and then the implications of it. What would be some of the just general ways that cluster randomized trials might be more complex than the RCT design, especially for those that are carrying out the trial? What are those key areas where it is a little bit more complex?
Yeah, so I mean, I think one of the main questions too is whether you really even have clusters that are similar to each other, right? So when you think about Canada, you can have urban areas, you can have more suburban and rural areas. Some of your clusters, if you're using hospitals, you may have very small community hospitals. And so you need to even first figure out is whether the clusters that you're comparing are similar to each other. And that may have some statistical implications as well. And that's why I said, even at the very beginning, make sure that you are engaging your statistician, because you want to see even within a particular cluster, whether there would be variation among the possible participants, say the patient populations in that cluster, how similar are they? Within, let's say a particular cluster in Nova Scotia, which is where I lived a long time ago, versus in, downtown Vancouver, it may be very, very different. And so when you have to compare, it adds other kinds of complexities in terms of how many clusters you may need to make sure that you have enough power, how many participants per cluster that you may need as well. There are times it may be more complicated because depending on how similar or different these clusters are, you may realize that, well, we only have enough funding for 10 clusters, or maybe only 10 clusters have agreed, but you may now also have to increase the sample size to make sure there is enough power. So certainly there are those complications from a statistical perspective. I'm not an expert, so can't answer more than that. But there are other kinds of complications as well from an ethical consent perspective. Sometimes people would ask me, well, who exactly is a research participant? And who should have to provide consent? I mentioned earlier as an example about how, let's say, if you want to use education intervention as the particular health service you're trying to study, and they may be implemented in a way that actually you want the healthcare providers to use it. But what you are studying is not just what the healthcare providers are doing, like are they really following the script and so on. You're really more interested in what is the patient outcomes. So are we using less restraints in the emergency room such that patients have higher satisfaction, less distress from the restraint and so on and so forth. So it raises questions in terms of who is giving consent, the healthcare providers that the hospital asked them to be part of. Well, that's part of the job. Can they actually say no to this, right? Or is it the patient? how would you even ask patients to consent or decline if, let's say, in this particular cluster, everyone has already been trained to using this particular, let's say, education intervention. So everybody has already been trained. When you say no, you can't ask for somebody who has not been trained. So there are other kinds of practical realities in terms of whether it's even feasible for people to consent or refuse consent.
Wow. So I'm sure everybody on the call today is thinking, okay, so where do we go when we are faced with, that comes across, we're going to conduct this cluster randomized trial. So I know we have more discussion. Please put your questions in the chat if you have any like that, so we can facilitate this great conversation. Terri, what are you thinking?
So yeah, just carrying on from that, it was very, very interesting the way you described that, because it kind of leads into my question, which was really about the institution being consenting. So is it, I mean, it's not, it could be practical, it could be more practical for the institution to be able to give consent because that's where the cluster is going to be located. And in your example of, applying this training program in the ED, and then, but the patient data is what's being collected or potentially being collected. The outcomes are being collected from the patient experience. And then they're not aware that they have been part of something that may be a trial. And so what are some of the ethical implications of that, and how would we work with that in order to really demonstrate that this is the most practicable way to go about the cluster trial?
It's a really good question. And I think especially in the context of what was being mentioned earlier too about learning health system. So when we say, well, patients don't necessarily even know they're part of a trial, one interesting question that we may want to ask is, what counts as a trial, right? In patients' mind, do patients actually expect, for example, that when they are in a hospital, let's say, that we do actually collect their clinical information? We may also collect other operational information to try to see whether there are ways to improve. So sometimes, and this came out in our study as well, that what counts as being at a trial is not, especially in the learning health system, is not as clear as before. I think that when we apply for funding, when we go through our EBs, that seems to be much more obvious to us, at least. But very often it isn't really that clear, especially when we're looking at what sometimes is being called like standard of care trials, so like comparing standard of care to maybe tweaking other kinds of health service implementation. So one question that we may want to ask is, when the study team looks at the patient data, which may have been collected for clinical purposes anyway, would the study team be looking at the data in de-identified manner? Would they know who the patients are? Or are they looking more at like aggregate data? So if it is aggregate data, de-identified, they don't know that Anita is part of this or whoever is part of it. They're really just looking at, okay, so let's say aggregate patient satisfaction, has that changed? Length of stay at the hospital, has that changed? Do we call code grade? What do we call it in Canada? So code grade is like violence, when there's violence. What is it called? Is it the same?
Yeah, I'm not sure. I'm sorry.
Okay. So there are metrics that you can still track at an aggregate level. There are times when, if you have minimal risk or no more than minimal risk, which is what the Ottawa statement also suggests. And especially, I would say especially, because I don't necessarily think there has to be both of these, but especially when it is just not practical to ask for consent. Because if you ask for consent, you don't have a way to really have people not say yes, or their data is still being part, or your intervention is still going to affect how you may be delivering care. So you really don't have patients who have a way to totally opt out. You may be able to opt out your data being included in that study, which may be a separate question, right? So I would say, is it minimal risk? Is it practical? How much burden is that going to be? Are there other ways to tell patients about general information about the study without actually having to go to informed consent as a way of inclusion?
So we do have 2 questions in our Q&A, which is great. I was just taking a look, Anita. I think I'm going to answer them not in the order they came in, because the second one really does seem to apply to what you were just talking about. We talked about the anonymous data from the participants. But the question is, do you also need to, blind or make anonymous the cluster itself, which clusters? And if you do, who would that be to? I think that's the question. Does the cluster also need to be anonymized for the purpose of the research? And at first I'm thinking, well, I'm not sure, how would you do that if it's by a facility or a site? Are there times where you actually would be blinded to the cluster, either the researchers or the healthcare professionals? And this was something we talked about, if you remember, when I first reached out, was this trial where the researchers administering consent were not blinded. They knew what cluster their participants would be in, if they were in the intervention yet or not yet on. It was a stepwise design. And the randomization process was such that it was individual consent. They consented, and after that they were randomized, like you would see with the traditional RCT, and said, oh, you're in the intervention group or you're in the non-intervention group. And so in that case, when they consented, they were blinded. The researcher was not blinded, but had to sort of make it like they didn't know until the envelope was opened. So there's, I'm just wondering, are there cases where actually that would have been better if the researcher had been blinded as well, the person administering informed consent? Would that have made it easier for everyone to be like, we don't actually, either of us don't know, versus them knowing? And are there scenarios where you blind the cluster to certain groups, and what groups?
It's an interesting question. I wasn't quite sure whether the question was asked in relation to just in general. Like, so probably it depends on who is even running that particular research trials, right? When I'm trying to think, like in publications, often we still have to mention, where the studies might be done. That I'm not sure whether. I'm just trying to think off the top of my head, are there particular ethical reasons to blind the clusters or not? And they're not obvious to me for ethical reasons why we need to blind that. In terms of whether, somebody who is, to seek consent, should they know something that the participants don't know? Maybe that's part of the question, right? And so that if I already know that you're going to be in the intervention versus the standard of care, I seem to know something more than you do. And I, may be in a quandary if somebody wants to only participate if they are going to be getting the intervention. Now, of course, I guess research coordinators not knowing would be a better way, perhaps in many ways, that they may not be in their tone, in how they approach the person, that they would not have any kind of bias, right? Because it's very possible if they know that this is an intervention, they may actually be more eager. So I think that there could be a case to be made about that, right? But I'm not too sure whether there are a lot more ethical concerns about knowing that. But I could certainly see why some people may have discomfort.
And I can see from the next question, or the posting from the anonymous attendee, was that clusters anonymized for results to be published. So, and they're talking about identification of a particular community as community A participants experience less depression, or if the community A sample size is a lot less, it is likely that the patients could be identified. So is there, that seems to me to be something that would be, in common sense, that would be the time that you might be not blinding, sorry, but making sure that it's anonymous. Is that a good ethical reason to do so at that point?
Yeah, and one thing I want to also point out, and this is an ethical consideration, it doesn't even have to be just about cluster randomized trials. And I think that this question actually helps to illustrate some of those complexities, which is that when we are studying and comparing clusters, one of the things that we want to be very careful about is whether we may re-stigmatize certain communities, right? So if we decide to not use a regular RCT and to compare clusters, and you're picking certain clusters because you think that they may have higher, let's say, rates of depression and so on and so forth. We have to be quite, I think that, do our due diligence in really asking questions in terms of whether some of the research and the use of the methodology and how it's being reported may actually re-stigmatize or perpetuate some of the stigmatization of certain communities. So I do think that when research teams decide to do cluster trials, you have to first justify why you're using a cluster design in the first place. And also I mentioned, I think in one of my last slides, to really consult the community in terms of whether they have concerns about how the trial is being designed, and to really educate about the life cycle from the time that you are collecting data, choosing clusters, to collecting data, to interpreting the data, and to disseminating your data. That having the community involvement would probably give you a much better sense in terms of whether attaching identity to the clusters would have other kinds of negative effects. So it's not just about the individual. Would the individual possibly be identified? Perhaps, right? So I do think that those would be situations where you may say is no longer minimal risk, right? Consent waivers are generally about whether it is feasible to conduct the research without the waiver and whether it's minimal risk. I'm not as concerned about the feasibility part. I am, but I don't think that is the only thing, because there are times when you can technically do it, but it would be very expensive and takes much, much longer time when there is no impact on the participants at all. However, if it is something that is not minimal risk, then I think that the bar has to be much higher in thinking about consent.
Yeah, I see we're getting closer to the end of our time together. And I do have one final question, but wondering, Terri, how about you? Were there one or two burning questions you had wanted to ask Anita?
I do. I have this one from having read the paper. Is it okay if I go ahead with that one, Alison?
Absolutely.
Okay, thanks. So in your draft paper, you referenced the double-edged conundrum where marginalized populations with less trust in the healthcare delivery and research may be less inclined to consent as individuals to participate, to have their data included in a study, and that this in turn creates selection bias that may perpetuate inequitable access to beneficial research. Do you have ideas on how we can socialize the benefits of a CRT without individual level consent and still advance reconciliation?
Yeah, I think that's a really good question. So maybe let me say a little bit about that double-edged sword first and what I'm getting at there, right? So in general, when we talk about how respect for participant autonomy requires that we ask everybody for consent, what that means is people can say no for any reason. It could be really good reason because that they have been burned before from other trials. It's too far for them to come to a research site and they have too many other responsibilities, so on and so forth. And there are also people who just will say no to anything for any reason. This may be a completely innocuous in terms from a harm or effect perspective. They would just say no. There are others who may just say no generally because they really just don't trust the system. I'm not saying that is an illegitimate concern. People who don't trust the system then generally are not included in research trials because they say no. What that means is that we may have much less data about these populations, about their concerns, or their exposure to various kinds of substances, let's say if you are doing trials on that, to see how they may respond and what treatments or what interventions may be most helpful to them. What that means is they would benefit less from research. So there is that one area that we don't want to simply include people who don't trust the system already. And then you just somehow, in a roundabout way say that, well, you know what, let's just not ask them for consent. Let's just include them anyway. That will even perpetuate more distrust, right? So that's why in general, we think that especially for marginalized populations or populations that have been socially marginalized, that we don't want to do that. But at the same time, I think that if we think about health services research, that you do want to have as many people as possible. I mentioned about the collaborative necessity. That if you don't have representative populations, you simply cannot have valid results that can apply to all population groups. So this is when I think that just individual level consent is not going to do that magic for us. We certainly have to have much more education in terms of why research needs to be conducted in the first place, how exactly that will be conducted. And I think this is the important part for reconciliation and so on, is that why do we think that collection of data, particularly from this population, will actually in the end benefit this population? And I think it's often this last part that people feel like there is no guarantee that even if I'm taking part of this, that the result of this study will have any benefit on us. In fact, we may be re-stigmatized, like the example we were talking about earlier. So why should I do that? So I think that a big part is really to think about why are we doing a study in the first place? And how do we know that this study and the populations we're trying to include would really be allowing us to promote more equitable health outcomes? So I mentioned earlier about patient advisory groups. They don't represent everyone in the community, but that would be at least a good step. The more that we can include the stakeholders, the better that we can also allow people to ask questions. So we're not waiving consent just because we don't want to tell people. If we're waiving consent for the right reasons, but allow people to still ask questions and help, perhaps even better, help to design the trials, then that can hopefully help us to promote more trust in the first place, so that you don't have to worry about less participation for some population groups.
Thank you for that. That gives us a lot really to think on, and really that really resonates around bringing those people into the conversation when you're designing the research and thinking about why it's even needed, versus at the part where you're now implementing the study and asking them to trust you through the process when they haven't been part of it from the beginning. So I'm going to skip my last question because you can't top this last 5 minutes that we just spent talking. But it was really going to be about the Ottawa statement you mentioned. And I'm just going to flag that our Nian is going to share with all the participants today, not only the paper that Anita and the team have recently, is it published now? Last it was in preprint.
Not yet, it's in preprint, yeah. Mm-hmm.
Yeah. And the Ottawa statement that Anita mentioned, and that will be some resources and reading for those that are interested in furthering their understanding of the topics today. So thank you very much, and I'll turn it back over to Jean.
Oh, thank you, everybody. Thank you, our viewing audience, for your presence today and participation and your fabulous questions. And I'd like to thank my guest hosts, Alison Orth and Terri Fleming. You led such an interesting and valuable discussion, and it was really quite lovely having you both here. Alison.
Yeah, absolutely. And Terri and I would, again, thank you, Anita, for joining us sharing this, your work and also your perspectives, and really helping to teach us in many ways about the things we need to think about, the ethical considerations when it comes to conducting cluster randomized trials. Thank you.
Yeah, thank you, Anita.
Thank you, Anita. I think I could have spent like 4 hours here talking about this. But I would like to thank also again our producer, Nando, the communications and coordinator at Clinical Trials BC. Thank you, Nan. He is going to highlight some of our upcoming events and provide you with some contact information.
Everyone, thank you for joining us today. Before we conclude, I would like to say that this broadcast were recorded, and the recording will be sent to you by email, and we'll upload that to our website. We have also the previous episodes available on our website for you. We will ask you to complete an evaluation survey. The results of the survey will help us evaluate the impacts of these sections and help informs our future program like this. As Alison mentioned before, I will share with you Anita's preprint paper and also some additional resources.
Great, thank you. So this was our third episode for this season. The season 3 series is again posted on the Clinical Trials BC website for viewing. We do hope to see you at the next Ask Us in May for the International Clinical Trials Day. Mark your calendars and don't miss it. Thank you and good afternoon.